All right, guys, welcome back. This is the Insights podcast from Neurocritical Care Society. As a reminder, the Insights podcast is based on the on-call content, which is published online. It's a continually updated textbook with experts in the field reviewing all of the latest guidelines and up-to-date literature. And so we really invite you to check this out. But we are very, very thankful for our sponsors, Biogen and Cerebral. And now a word from our sponsor.
Time is brain when it comes to seizures. Cerebral point-of-care EEG empowers the bedside team to detect or rule out seizure activity in minutes. To learn more, visit cerebral.com.
All right. Well, welcome back, Salia. It's been a while.
Yeah, thanks for having me. Thanks for being here. This has been great. I'm happy to be back and do all of this again and have so much fun with neurocritical care.
Love it. So we left off when we were doing, a very, core topic in neurocritical care, which is the management of acute ischemic stroke. And today we're going to flip to the other side of the stroke coin, the sort of hemorrhagic stroke, and kind of go through, the clinical approach to when this patient walks in the door. And so what I really want to emphasize in sort of starting out from the clinical perspective is that it is impossible to tell if a patient is having an ischemic stroke or hemorrhagic stroke just by looking at the patient. There's been a lot of effort to see, are there some more telltale signs? Like, are this, intracranial hemorrhage patients, are they more hypertensive? Are they sleepier? And while that might be true in some cases, it's not reliable. So again, this patient, like just as you do for any ischemic stroke alert, the same principles apply for hemorrhagic stroke. And that's when you notice that a patient has focal deficits that you think localize to, one lobe of the hemispheres or the cerebellum, you really need to get, or brainstem, you really need to get that patient to the CT scanner to figure out if they are having, an ischemic event and then qualify for all the therapy we talked about in the last two episodes, or if this is an ICH. And once you make that determination, then it becomes kind of a algorithm for the management of these patients up front. The big focus being ABCs, which for these patients, obviously the airway and the breathing. But then we're thinking a lot about the circulation, and then that, their blood pressure. And so Celia, I was wondering, since blood pressure control is really the mainstay of treatment for these patients, what are some clinical tips to take for the bedside when you're thinking about, how do I lower the blood pressure? How much do I lower the blood pressure? What agent is best for lowering the blood pressure? Since that's such a big decision for this patient population.
There's a lot of debate probably about what is the right target, and we can talk about that. I think before even we get there, the new guidelines, the 2022 ICH guidelines, talk about the fact that the sooner the better, and they specifically talk about that within 2 hours of ICH, you really want to get on the blood pressure control, and the idea is that you get them within the goal within the first hour of starting your antihypertensive medication. Now, what goal did we have in mind? I think not to go over all the details, but we had the ATAC trial and the Interact trial. I think there was a lot of debate. Do you do less than 180? Do you do less than 140? Guess what? The guidelines say 130 to 150 now. So I think 140 is what we typically kind of think about. And, there is also some discussion that in patients with mild to moderate ICH, getting the blood pressure less than 130 is going to be harmful. So that's just something to keep in mind. 130 to 150 is the goal. If they come in with blood pressure within 150 to 220, I think it's a little bit more gray when people come in with blood pressure of more than 220. I think that's when we talk about, do we do, percentage reduction, 10 to 15% from that initial presentation already now. But I think in patients with massive ICH, it's again, like the evidence is gray. They don't have specific, recommendations for the target. A lot of these patients have to go for surgical interventions and all of that. So this is mostly for mild to moderate ICH. Again, they don't come in with blood pressure of over 220. The target is 130 to 150, and don't get them below 130 because that's harmful. Next question is, okay, what agent do you use? I think just like anything in critical care, the basic of critical care, I think management is that you want an agent that works really fast, that can be given IV and that also is easily titratable, right? You don't want to give a drug that stays in the system forever and you can't really titrate, or it's not quick onset. And based on that, I think the agents that come into mind, the agents that typically are used are IV nicardipine, which is quick onset, it's easily titratable, it's a calcium channel blocker. Another calcium channel blocker that some institutions may have is clofidipine. It's also quick on, actually quicker on, quicker off. That may be something that is nice about it, but it's expensive. Not a lot of institutions have that. And honestly, there are some retrospective reviews that looked at these two agents and there was no difference in outcomes when they look at ICH expansion. So if you don't have clofidipine, do not worry. Nicardipine is probably as great and it does the job. What are the other agents? Think IV esmolol, if your patient's heart rate can tolerate that, because it is used for blood pressure, but it is a beta blocker and it can drop heart rate to some degree. It's something to keep in mind. IV labetalol, if you don't have the capacity to do an infusion and you just need to use intermittent doses, IV labetalol is a good option. Lastly, I kind of wanted to mention that although we talk about IV hydralazine, this is probably not the preferred agent in this setting. You really don't want to use it unless you absolutely are out of all the other options, just because it is more unpredictable as far as the onset and the outcomes and the blood pressure management. So that's usually the last resort. And then something to also highlight is that you absolutely don't want to use your nitrates in this setting agents, and they can possibly increase ICP.
I love that. I mean, I just would echo, I feel like hydralazine has such a just really unpredictable effect. And for some patients, it drops them too much, and others, it doesn't do anything. The other thing I would say for these patients is if you have the capacity at your shop to put in an A-line, that's really helpful. Most places you can get an A-line in really quickly, and that allows for like the continual monitoring of this. It makes it easier for the nurses to titrate this consistently. We're not having big swings from, taking the blood pressure really high and then dropping it too low, then turning off the infusion and the blood pressure rises. We want to have a controlled downslope to that target of 130 to 150 if your patient is presenting with a blood pressure less than 220. I got to tell you, like a lot of patients where I work come in with blood pressures way higher than 220. And for them, we're doing exactly what Salia was saying, which is just a percentage reduction. So usually getting them down to like less than 180, less than 160, 70. Again, because we're going to harm their kidneys. If they are just chronically used to seeing a very high blood pressure, and then we just box their kidneys, that leads to all sorts of like downstream consequences with sort of the AKI. And then you have to figure out, is this person anticoagulated, right? Because the other thing that we can do to limit secondary brain injury is make sure that we are reversing any coagulopathy. So this gets tricky. Salia, like walk us through what the guidelines say. How am I going to even like determine if the patient's on a DOAC, if there's not family around? Like this gets kind of complicated.
You're right on. It's very complicated. I think a few maybe principles to think about, and then hopefully that can help us. I think number one is that if you have any suspicion that this patient is on anticoagulation, do not wait for any levels to come back before reversing them. This is true for everything, for warfarin, DOACs, all the things, and we'll go through the specifics of all of that. Obviously, if when they took it, that's amazing. And you can figure out when was the last dose and think about, did they even, qualify to be reversed? So now walking through how we decide, where do we go from here? Again, I think for the majority of these agents, something that I keep talking about and teaching in our unit is that I go by the rule of 48-hour mark, meaning 48 hours is pretty safe to think about these patients should be reversed. Again, I think this is a multidisciplinary discussion. But I think for the majority of agents, 48 hours is probably a good time frame to have in mind. And that's really based on 3 to 5 half-lives of these drugs, given that the half-life ranges from 10 to 12 hours for the majority of these agents, again, in a patient with normal renal function. I wanted to kind of walk us through individual agents. So let's start with warfarin, maybe. Again, we don't see warfarin as much as we used to, which is nice. But I think there was a time that evidence really kind of suggested that you have to wait for INR to come back before you reverse people. There is plenty of literature now talking about fixed dosing of 4-factor PCC, meaning for ICH in these cases, you can just give a fixed dose and you don't really have to worry about these people, the INR coming back to reverse that. Now, the target INR is less than 1.4. So if your INR is still above 1.4 after that fixed dose and you're still concerned, you can think about a supplemental dose. Again, this could be a discussion with the team based on risk factors and everything else. So again, no need to wait for INR. You have that capability to do a fixed dose 4-factor PCC. Now, what about heparin or Lovenox? Protamine is the agent of choice. I think that one's a little bit easier just because a lot of people are familiar with that. And then we get to 10A inhibitors, right? Apixaban, rivaroxaban, doxaban, all those fun agents that we see more and more these days. So this is where I think it gets controversial. And I think this is
controversial. So much controversy.
So I think because the evidence isn't there, I'll tell you what I have seen from evidence and what we do and all of that. But again, very controversial, just like Casey said. I think you can talk to 10 people in one room and everyone will give you a different answer. I think the evidence, though, is that we do not have any head-to-head trials looking at these two agents, Kcentra, which is 4-factor PCC, and Indexinate in the same population, the same kind of, randomized trial. And there is some hope that we have an ongoing trial that is going to get published soon, and hopefully that will answer some of those questions, but we don't have anything yet. Now, some institutions have looked at their experience, meaning they looked at Kcentra alone and they look at Indexinate alone, and they published their outcomes. And guess what? What we know from these, again, retrospective, so we have to think about that. What we know is that the efficacy is probably comparable. Again, I say probably because they look at different definitions of ICH hemostasis. They had different patient populations and all of that, and it was not randomized and all of that. But then one thing that also we found out was that Kcentra was associated with a lower risk of thrombosis. So as of now, the retrospective studies that are published, again, retrospective, that's the key here, they saw thrombosis of around 4 to 5%. And then fixed ICH was a big study that came from the Neurocritical Care Society. And then for the Indexinate, the NX4 actually reported a higher rate, about 10% risk of thrombosis. So that's just something to keep in mind. I think, to me, whatever you have in your institution that is faster, you have a protocol for it, that you can activate that process and you can get the approval and you can get that situation and that ball rolling fast, that's what I would do. And one piece of information to also share is that people ask about, okay, you are saying that do not send for any levels before reversing people. I still, to this date, I believe in that. If your suspicion is high, you don't want to send 10A levels, you don't want to send INR, any of that. People ask about, what about, especially with Indexinate, do you send 10A levels after? You really should not. The idea is that, in the NX4, they actually had calibrated 10A levels for the agent that they were looking at. So apixaban, rivaroxaban, all of that. And a lot of institutions don't have that. And even an NX4 showed that majority of people's 10A levels got reduced, but not everyone's level got reduced. So the idea was that if you achieve hemostasis with your ICH and that's confirmed, then you're done.
Totally. I think that's such great advice. Give whatever is available fastest, right? If that's 4-factor PCC, just give that. The dosing for that, sort of, we are using 25 to 50 international units per kg. Salia, is that what y'all are using as well?
Are we talking about warfarin reversal or DOAC reversal?
Sorry, for DOAC reversal.
So we actually have a fixed dosing now, which is making it really easy. So for warfarin reversal, we have 1,500 units. And for based on body weight, obviously, it's a little bit more complicated than that, meaning there's a threshold of body weight below and above, but 1,500 is universally what for typical average people. And then for DOAC-related ICH, we use 2,000 units.
That's awesome. I think whatever we can do to simplify this process, the point is don't wait until this patient's rolling through the door to make a decision about how you're going to reverse. Know what your hospital's policy is like from the beginning. Know what people are comfortable with, what the pharmacist is comfortable with, how long it's going to take to get these agents to bedside before you're actually in the moment dealing with these patients. All right. So we've identified the bleed. We have controlled their blood pressure. We have addressed whether or not they're anticoagulated and have appropriately reversed them. The final thing to sort of think about in the upfront management of these ICH patients is whether or not there is probable ICP issues or hydrocephalus. Many of our patients who have deep basal ganglia or thalamic bleeds will also have IVH. Not every single IVH needs an external ventricular drain, but a lot of patients do. And I think that's when you really need close collaboration with a neurosurgical colleague. So we know that that type of surgical intervention really is life-saving for many patients. Surgical options beyond just placing an EVD for hydrocephalus management, that's a little trickier. The trials really have not been definitive that we help people with surgical treatments. We keep trying to find who is the right patient population, what's the right time, what is the right surgical technique, how do we make this most minimally invasive? Again, work closely with your neurosurgical colleagues for this patient population. We're going to spend a whole episode talking about sort of medical management of intracranial pressure. So we'll skip that now. Just kind of keep in mind, like, does this patient look like they're getting sleepy? Is there evidence of uncal or transtentorial herniation? And then think about how am I going to temporize that? All right, Salia, so any like parting wisdom in terms of ICH management takeaway points?
I think this covered it all. I think just to highlight and echo that time is brain, really, whatever you can do to fastest blood pressure management, I think reversal into setting of AC related ICH, those two really should happen kind of hand in hand. I think just one thing to highlight also that in all the studies that looked at ICH reversal into setting of anticoagulation, not a lot of them actually reported blood pressure management in that time frame. So it's just one thing to think about whenever you're looking at these trials. Are they reporting blood pressure? What was the blood pressure? What was that range during that first 6 hours, which is, the initial expansion and damage happens. So some of those pearls, but I think hopefully this can help people with their initial management of ICH into ED or other ICUs or even neurocritical care. If you're new and you want to learn the basics and the pearls, I think hopefully this is helpful.
I love it. All right, well, we'll be back with another episode, this time focused on intracranial pressure. And so we hope you will stick around and join us. And again, thanks so much for listening.
Thank you. Bye, guys.